we needed riboflavin in the cornea. In this case, we still used iontophoresis, and we needed oxygen in the cornea. And in that specific publication, we simply slowed down the treatment. Yes, we didn't go faster, we went slower. We went from half an hour, Dresden protocol, to 1 hour. And then we had a very efficient, strong cross-linking. Of course, as a clinician, I don't want to spend 1 hour, but it was a proof of concept. So we knew that by tweaking the irradiation time and maybe the power and intensity and fluence, we could work without oxygen goggles. You know that the company Avedro has oxygen goggles. That's another way you can do it. But I didn't want oxygen goggles on the patient's eyes because it makes a very simple and elegant method more technology heavy. So in 2019, we had the first well-functioning epi-on. Everything that was before was almost sham treatment. And I remember we had to write a very, very strong public article. We, as in Theo Seiler, the inventor, Eberhard Spörl, Paolo Vinciguerra, Brad Wendelband, and myself, and we said, stop CXL USA. Stop doing epi-on, that does not work. I have retreated many, many patients that had epi-on in the US and that were just simply progressing because they used an epi-on that simply would not work. Now, in 2019, the first functioning epi-on came from Avedro. And what they did, they used additional oxygen. And in some cases, you also need iontophoresis. As you can see, these types of epi-on cross-linking work, but they require much more than just the cross-linking lamp and riboflavin. So our personal aim was, how can we do efficient epi-on cross-linking without oxygen goggles, just with the oxygen in the surrounding air? And how can we avoid iontophoresis? Knowing that we have all these pieces of a puzzle. This is how epi-on worked in 2018-19. So by using iontophoresis to push the riboflavin in, and by having oxygen goggles. And the first to overcome oxygen was Cosimo Mazzotta from Italy. What he managed to do, and he published this 5 years ago already, he used the following combination. Used normal air, but he modified the light settings to high intensity, high fluence, pulsed, gentle acceleration. And then he had very good results, similar to the 10-minute protocol epi-off. But Cosimo still used iontophoresis. And my group during Corona was working for almost 2 years. Can we avoid iontophoresis? Can we do this with what we call penetration enhancers? So substances that open the epithelium only transitory to let the riboflavin through. In 2015, we had a first paper on penetration enhancers and epi-on, and that old epi-on was not too successful because the penetration enhancers were too aggressive and they would destroy the epithelium. But now, after almost 2 years of experiments with the multiphoton microscope here in Zurich at the university, we found a riboflavin, as you can see in the upper left, that gives very good penetration without harming the epithelium. So we can do epi-on this way. And that's amazing. That's not an OR because we don't need a sterile environment. The timeline below shows you what is needed for the epi-on to work. And again, no iontophoresis, no oxygen, just riboflavin, the lamp, and a lot of time. You need 38 minutes to prepare the patient. And then there is 15 minutes of irradiation. Important for you as doctors, you come in the last 15 minutes because everything before is simply drops and drops and drops. So if you have a trustworthy nurse or technician, they can take care until the irradiation step comes. Now, having done this, I would expect you to ask me first, well, that's nice, Professor Hafezi, but show us the data. We cannot simply believe your word. Let me show you the data. This is the Epi-On we are using now. And it is available starting autumn on the CI device. These are the lab data, and the work has been submitted and should be published in 2 or 3 months. So in the laboratory, our Epi-On is similar to a 10-minute Epi-Off. So really solid cross-linking. And we started almost 4 years ago with the clinical study, and we compared our Epi-On to the standard 10-minute Epi-Off, and it is absolutely comparable in all the aspects, which means that we also have a demarcation line of 230 micron in Epi-On. And it is absolutely, again here, comparable to the standard 10-minute Epi-On. And this is a real paradigm shift for multiple reasons. First of all, this is the Al-Zatari refugee camp in Jordan. And last year we went there, and 70,000 Syrian refugees, all they have is one slit lamp. That's the Department of Ophthalmology, one single slit lamp. So we were able to treat several already diagnosed kids just by having a backpack, our CI technology, our own riboflavin that we developed, and a strong power bank. That was it. And this is a real game changer. Also a real game changer because, again here, for example, treatment in Uzbekistan, and there is no need for a sterile environment. This is an Epi-On procedure. Works really like a charm. Now, again, we don't need iontophoresis anymore. We don't need additional oxygen. The biomechanics is similar to a standard accelerated cross-linking. So a little less than Dresden protocol, but for most routine cases, more than enough. And it will be available in late 2025. Now, the paradigm change is also that because of the very low risk profile, I started being more proactive in my approaches. If I have a borderline patient that I follow 2 or 3 times, I'm more prone now to say, let's rather do the cross-linking because the risk is almost zero and the benefit is clear. So I'm being more proactive in my approaches. The second element I wanted to show you is ultra-thin corneas. You know, when Eberhard Spörl had the job from Theo Seiler, Theo told him, develop the technical settings for cross-linking. Eberhard Spörl took what was available at the time in the early mid-1990s. 3 milliwatt LEDs were the state-of-the-art, and Eberhard, as a physicist, thought, half an hour is probably what a patient can tolerate. Longer will be difficult. This is how the Dresden protocol was born, and it happens to be one of the most solid protocols we have to date, and it limits the depth of treatment to 400 micron. So, knowing this, how can we do a nice cross-linking like you see here in a 220 micron stromal cornea? Well, I know that you must have many, many patients with corneas thinner than 400. Let's have a historical look back. I see the audience. Can you just raise your hand? How many of you treat thin corneas? I don't see many hands coming up. How many of you do cross-linking? Okay, so the question was, how can such thin corneas be treated? The very first paper on the topic is from our group in Zurich, and we developed hypoosmolaric or hypotonic riboflavin, so swelling of the cornea. And this worked quite well. A few years later, Susan Jacob from India proposed contact lens assisted cross-linking. And if you ask me today, do I use any of these techniques? My answer is no. I don't use my own technique. I don't use Susan's technique. Let me show you why. My own technique, using swelling of the cornea, works nice biomechanically. This has been even published by Wollensack. So you can swell a cornea, do cross-linking, and the reaction is really good. The problem is, it is not predictable. If you do an abrasio and you try to swell a cornea, some corneas react a lot, others almost do not react. So worst case, you are stuck with a very thin cornea in the midst of a procedure and you cannot move on. So it is unpredictable. So why not use the contact lens like Susan does? Because the best contact lens in the world is an obstacle to oxygen. And this is not a hypothesis. We published on this 1 year after Susan got the data. We were able to show that based on this 11-year-old paper, oxygen is necessary. We were able to show that if you use a contact lens, you lose 30% of efficacy. We showed this very clearly, 30% less efficient. So back in 2016-17, we were thinking, so the paper came out in 2021, we were thinking these two techniques, swelling or contact lens, what they do is they adapt the tissue to my machine. Does this really make sense? Think of cataract surgery. If you are in the OR and the first patient has a very, very soft nucleus, almost clear lens, will you adapt the settings of your machine? Probably, right? You would change the vacuum, the surge, whatever, to be gentle. Then the next patient has a rock hard black cataract. Imagine you keep the machine the same. You do 20 seconds of phaco, 40 seconds of phaco. And after a few minutes, you would say, phaco technology is not working. It is not a good technology because I cannot do cataract surgery. No, you wouldn't do this. You would adapt your technical settings. You should do the same in cross-linking. Not adapt the tissue to the technique, but rather the technique to the tissue. And this is what we started doing in 2016. We published 1 year later in 2017 an algorithm on how to adapt the total energy to the depth, to the thickness of the cornea. So in other words, if you have a very thick cornea of 400, you have more total energy. And if the cornea is thinner, you have less total energy. And this is not a simple relationship, it's a quite complex one. You have seen the formula because it takes into account riboflavin diffusion and oxygen availability. But having done so, we went into a clinical study that was published in the American Journal. And in the past 4 years, it was cited more than 120 times. So it has been adopted globally. And it creates a table. I think many of the cross-linking surgeons have this table because we decided not to patent it, not to protect it, but to give it as public knowledge. So anybody with any machine can use this algorithm to treat very thin corneas. Now, the approach is now very uniform. You do an abrasio, you give the riboflavin, and then, very important, you need to know where to expect the thinnest point, and you need to measure the thinnest point because the speculum and the riboflavin, they will modify your stromal thickness. Even the speculum alone can thin the cornea by 100 micron, 100 micron, just by having a speculum in for 10 minutes. So measure your thickness, take this value, look at the table and irradiate. The entire algorithm is programmed into the CI device technology. And see, now you see the difference between a working model, which I hold here, this is 10 years old, and the actual machine. So, what are the results? The results are quite amazing. We have 82% success after 2 years. It's not as much as Dresden protocol, but it's not the same type of keratoconus. Look at this, 90 diopters of Kmax, not even 300 micron of stroma, and still 82% success. Some colleagues ask us, why do you even cross-link such a cornea? Well, we cross-link these because that patient sees 20/20 with a scleral lens. So as long as vision can be restored with scleral lenses, yes, we should absolutely keep the patient's cornea. What about endothelial cell density? It was in the meanwhile checked by two different groups, one from Switzerland, one from Brazil. Even though the thinnest cornea we treat are 200 micron, there is no loss in endothelial cells because the fluence is adapted to the tissue. And it opens new alleys. Being able to treat such thin corneas, you can even treat keratoglobus, so extremely thin corneas. And we haven't stopped there. We started with the first generation sub 400. In the meantime, we have developed a second generation sub 400 that uses way more energy and is even more efficient. This one will be published now and will replace the first generation. The results of first and second generation are absolutely comparable, although our Kmax is even higher in the second generation. And again, endothelial cell density, even in these high fluence applications, is the same. So in conclusion, we can treat down to 200 micron of stroma safely. We can even treat keratoglobus. Everything is integrated in the CI. And where we are standing right now is having the first generation sub 400 that is already available. The second generation sub 400 coming this year, and it is epi-off. But now, what we have been starting in our center in ELSA since 1 year is epi-on sub 400, and that's the ultimate goal. Having a sub 400 protocol that is without removal of the epithelium. Then we can treat any thickness epi-on. This is something that will take maybe 2 more years. Thank you for your attention.
Any questions from the audience? I have a question for you, Farhad, regarding cross-linking for post-LASIK ectasia. Because we know it's different than keratoconus. If you are finding a case with very thin cornea and you're using the sub 400 protocols for those cases, because I have seen many cases with very thin cornea, more common in post-LASIK ectasia rather than keratoconus with valuable visual acuity. So we do cross-linking for those cases. Do we have any special consideration putting in mind that if we are just cross-linking the flap, you're not doing anything because it's not biomechanically active in the process of biomechanics of the cornea?
Yes. First of all, when we started cross-linking ectasia, we published the very first paper in the field in 2007. So we looked at it very early. And now with OCTs, we see that many of these ectasias have extremely thick flaps from the old microkeratomes, like 220 micron. So we need a cross-linking that goes, as you say, far beyond these 200 something of the flap. And in a nutshell, I always tell my patients the success rate that we have with keratoconus is not the same in ectasia. I'm happy if we have an 80% success rate because out of all forms of ectasia, post-operative ectasia is the most aggressive. So I prepare the patients for a retreatment and I retreat after 6 months if necessary. But I also always use the strongest protocol available. The strongest protocol available until recently was the Dresden protocol. And we have developed now in the past 4 years, there was simply not enough time to show you all the data. I did a 3-hour course for another university last week in Taiwan. But we have developed a high fluence 10 joule epi-off that is even stronger than Dresden and only takes 9 minutes 15. It will be published in the next weeks. So since a few years, I take this very high fluence protocol. Why? Because my demarcation line goes down to 320. And so I am very deep. And I can tweak this even if the cornea is too thin for that. But the endothelium has a very large resistance to UVA-induced threshold. So I'm using the strongest possible protocol. I even decenter and irradiate the limbus in a peripheral ectasia after LASIK. Do not be scared to irradiate the limbus from 3 o'clock to 9 o'clock. You will not decompensate the limbal stem cells. I haven't seen in 27 years of publications on cross-linking a single report on clear limbal stem cell deficiency after cross-linking. So we are safe here. But decenter, use the strongest protocol. For now, use Dresden, and soon you will have the 10 joule that is even a little stronger.
Thank you. Do we have any more questions?
There is a question in the Q&A from Imad. He says, how much does it cost? I assume you refer to the CI technology. I'm the chief scientific officer. I'm not involved in pricing. Pricing can be different in any country, but the distributor for Egypt is Medicals International. So please contact Medicals if you want to know more about the device. I know it's registered in Egypt. It's available in Egypt. So